Dive on into motor development. So motor development is going to be important for pediatric populations, but also for adult populations who have suffered a neurological deficit because there's often a regression in motor development when there's been a neurologic injury or insult. And so it's important for the pediatric populations to understand how they're supposed to grow and what goal we're trying to get them to, because a patient who is not progressing at their appropriate developmental age, our goals end up being whatever their developmental milestones are. But also, we can return to those things in patients following a CVA or a spinal cord injury when we're trying to restore mobility, because taking it back to the foundation is how we can get the best neuroplasticity responses. We have a few different concepts that we're going to look at in regards to motor development, and different theorists that we're going to want to understand so that we can get a gross understanding of what developmental milestones should be like and what motor development progresses like, and as well as psychological development if we're really getting down to it, because motor development tends to parallel that psychological development. And so if we look at the lifespan concept, typical motor development increases over time, so we can jump farther, run faster over time. Motor performance peaks in early adolescence and early adulthood, with older adults performing motor activities more slowly and taking longer to learn new motor skills. Motor development includes all motor changes occurring as a part of a continuous circular process, so there's constant learning. And movement develops within three domains. So we have our physical, psychological, and sociological domains. Physical is going to be our things like walking milestones, getting a driver's license. Psychological is going to be the matter of being able to understand simple concepts and getting along with others. And I would argue that that kind of also fits into the sociological with the relationships and conflict resolution. And so we'll see overlap within all three of those domains. People do not develop in a single constrained course or developmental trajectory. There's variability between individuals, and so while we learn these milestones for general populations, it's important to also keep in mind that there's variability between patients, and how do we consider that individual's variability to reach the functional goals. Development is really the adaptive capacity of the person. And so if they can't developmentally achieve a skill, can we adapt their surroundings to make them functional? Development is not complete at maturity. It is a lifelong occurrence. So we look at development periods. We have infancy, childhood, adolescence, early adulthood, middle adulthood, and older adulthood. And this is broken down in table 4.1 in your textbook. But age is the most useful way to measure change in development because it's a universal marker of biological, psychological, and social progression. And while there are slight differences in how age is determined based on different countries, overall we look at age as a chronological assessment where you're within 6 months of being the same age as somebody developmentally when you give your year age number. Infants are going to progress into children, who then progress into adolescence, and then adults, and then we progress through the stages of adulthood. The stages of cognitive development are associated with age as well as the social expectations regarding the ability of an individual to accept certain roles and functions. And so we're going to look at that as we look through Erikson's model and Maslow's hierarchy here in a minute. But infancy, we're looking at birth to 2 years. We'll talk about later how the toddler period starts at 12 months, but infancy as a whole we look at as from birth to 2 years. Childhood begins at 2. In females, it's 2 to 10. In males, it's 2 to 12 because females tend to hit maturity earlier than males. Adolescence begins at age 10 for females and goes to age 18 for females, and then begins at 12 for males and goes to age 20 for males. So it's important to note that adolescence spans an 8-year time regardless of what age it starts. And then early adulthood is up until 40 years, and then middle adulthood is 40 to 70 years, and then older adulthood is 70 years until you die. The first period of development spans the initial 2 years, and so we talked about that's infancy, and this is when the infant establishes trust with the caregiver and learns to be autonomous. They use sensory information to cue movement and use movement to explore and learn. So at this stage of life, there's a big circle between sensory stimuli and motor development. And if we don't provide enough sensory stimuli, then we're not engaging the child enough to make them want to explore their environment to promote that motor development. And so sensory integration is huge in this area. Childhood, beginning at 2 years and continuing to adolescence, fosters the initiative to plan and execute movement and solve daily problems. They begin to use language and symbols to represent things. Thinking is pre-operational, and reasoning is typically centered on the self. And they begin to establish a self-image. In adolescence, this is, again, we talk 8 years regardless of when it begins. This is where they begin to solve abstract problems. The physical and social emotional changes are huge. Cognitively, the teenager moves to formal operation stage, and the time of change, the identity is forged and values are embraced. So this is a big period of evolution in human development, and there's a lot of identity construction that happens during adolescence and the establishment of those values that guide the person into adulthood. Adulthood is the longest time period of human life, and it is achieved by 20 years biologically and psychologically. And so we want to look at the difference between, yes, the biological age talks about our chronological development, but the psychological age factors into the mental capacity. And we will talk about that again, looking at Erikson's model here in a little bit. There can be a 5-year transition period from late adolescence to early adulthood that is marked by this overlap. And so you see characteristics of both adolescence and adulthood during this 5-year transition period that can begin as early as 17 and extend as late into age 22. So Erikson's model, or 8 stages of development, talks about each lifespan period and then what happens psychologically during that stage. So infancy is the trust versus mistrust stage, and that's going to be characterized by the child developing self-trust and their attachment and ability to trust parents' return and what their attachment to others around them is like. Late infancy is going to progress into the autonomy versus shame or doubt stage, and this is characteristic of the child finding independence and being able to regulate for self-control and controlling some of those emotional outbursts, and that's why we see more of the temper tantrums in toddlers, because they're learning that autonomy for self-regulation. Childhood in the preschool age is the initiative versus guilt stage. This is where children begin to initiate their own activities. School age is the industry versus inferiority. And so in working on projects for recognition, are they finding themselves industrious, or are they finding themselves less than compared to their peers? Adolescence stage is marked by identity versus role confusion. We talked about adolescence being a big stage of figuring out who oneself is, and so that plays very much so into the psychological development as well. So this is where the adolescent is going to establish their sense of self, both physically, socially, and sexually. Early adulthood is going to be the intimacy versus isolation stage that's characterized by establishing relationships with significant others and progressing those significant relationships. Middle adulthood progresses to generativity versus stagnation, and this is the stage of life where people tend to reflect upon whether or not what they are doing has just become mundane and they are stagnant, or are they still generating things? Do they still feel productive and useful to society? Are they able to contribute to the next generation of their family's growth and those such things? And then late adulthood is going to be the ego integrity versus despair stage. And this is kind of that wrapping up of life, psychological assessment. Did my life make me feel complete? And it's a sense of wholeness, vitality, and wisdom. And there's a breakdown of this table on page 68 in your textbook. Each person, whether child or adult, is going to have interactions with people in different circles of their life. And so Bronfenbrenner's ecological model is an infographic to kind of describe those relationships. And so we see the child at the center of it, and who they are as a person makes up the center of that ecological model. And then out from there, it's who they interact with. So peers, family, school, church groups, that's going to be their microsystem. And then building out from there, we have extended family, we have neighbors, we have the people that they don't interact with necessarily on a daily basis, but they do have some connection to, and that's going to make up the exosystem. And then the macro system is going to be society at large and how sociological factors influence the child. And so we have to understand that, yes, the people closest to the child have the greatest influence, but all of these layers are constantly pressing in on the child or the patient of any matter. And if you fail to consider each layer of their ecosystem, you're not going to identify where they might be experiencing motor development issues, psychological development issues, or sociological development issues. Maslow's hierarchy describes development as a progression of mastery. And so it's this pyramid where once you have built the foundation, you can progress on to the next layer above it. And you can't progress on to the next layer above it until you have solidified the foundation. And so this starts with meeting the most basic psychological needs to survive, or physiological needs to survive, rather. Being able to secure food, water, eliminate bowel and bladder, those things. Once physiological needs have been met, then a person can worry about their safety. Once safety has been addressed, then they can worry about love, belongingness, and affection. Once a person feels that they have love, belongingness, and affection, they can then worry about their esteem. And then self-actualization is the highest of Maslow's hierarchy, and one can't reach self-actualization until they have developed that sense of self-esteem. A self-actualized person is self-assured, autonomous, and independent, oriented to solving problems, and is not self-absorbed. Paget's stages of cognitive development only reflects on the first 2 years because that's the greatest rate of cognitive development occurs. And so basing his theory off of those first 2 years, he's able to map out this cognitive development through to adulthood. And so looking at these stages again helps us kind of identify how our patient is going to learn based on what stage of life they're in. Infancy is going to correlate with the sensory motor stage of life, and those characteristics are going to include the pairing of sensory and motor reflex to create purposeful activity. As the child progresses from infancy to the preschool age, they become pre-operational, meaning that they have unidimensional awareness of their environment and they begin to use symbols. The school-age child has concrete operational processing, and so they solve problems with real objects, classification and conservation. And then the pubescent stage is going to be our formal operation, where there's more abstract problem solving, induction and deduction, and the ability to critically reason through things. And so the demands that you place on the patient is going to depend on which stage of cognitive development they're in. And so it's important to correlate the age with that stage, but it's also important to look at your patient outside the context of their biological age and assess if their biological age matches up with their cognitive stage of development. Cognition is extremely important for motor development because of that sensory loop. And so without the ability to apply meaning to the things that you are sensing, then there's no reason to create purposeful meaning or purposeful movement. And so the ability to process and have cognitive awareness of sensory stimuli to produce movements is extremely important in motor development. A child with intellectual disability may not have the ability to learn movement skills at the same rate as a child with average intelligence. Changes decreased in all areas, including biological, psychological, and sociological, and each of those can affect the other. So cognition can influence motor development can influence cognition. And so again, it comes back to that loop. The child must perceive the world and the objects in the world as being real before they can really think about purposeful movement. And so object permanence is an important part of motor development. And you can think about this as, being able to play peekaboo with a child. They really think that you have disappeared behind your hands when they do not have object permanence. And so without the establishment of object permanence, they have no reason to try to seek something out. Why try to move to reach something that you can see if you feel as though that thing is not real or is going to disappear? And so object permanence is important to entice the child to engage in object exploration. Once they've established object permanence, they're going to progress to joint attention. And this is what happens when two individuals attend to the same object or event. And we participate in joint attention when we do playtime with kids, when we are doing the same play, but we are sharing the perspective with them. So whether that's pretend play or playing with the same object, we are actively participating. Joint attention affords the opportunity to create a zone of proximal development. And a zone of proximal development is basically that area of development that we push to try to get a little bit more movement, a little bit more mobility, a little bit more motor development that may not be able to be retained, but it's pushed in to extend our developmental abilities. And so in pediatric work especially, joint attention is an important aspect of interventions, because in order to appropriately establish that zone of proximal development, we have to jointly attend to the activity with the child to take away the things that they utilize to make it easier and add a challenge as they are able to progress. The dynamic systems theory of motor development says that movement emerges from the interaction of multiple body systems. And so without the interaction of those systems, then we wouldn't get movement. It incorporates biomechanical aspects of the mover, the developmental status of the nervous system, and the environmental context in which the movement occurs, and the task to be accomplished by the movement. It is both a motor control and a motor development theory. The brain and neuromotor systems must interact to meet the demands of the mover. We can compare this against the neuronal group selection theory, which says that motor skills result from the interaction of developing body dynamics and the structure or functions of the brain. We have 3 requirements for it to be effective. There has to be a basic repertoire of the movement present in the person's brain already to make that connections with. There has to be sensory information available to identify or select the adapting forms of movement. And there has to be a way to strengthen a preferred movement response. And so these are different theories that can be utilized to select appropriate interventions to achieve appropriate motor development. I can't really tell you that there's research to support one more than the other as far as intervention selection. I think it's really more important to understand that there's a combination of these theories working together to promote motor development. Epigenesis is a theory of development that states a human being grows and develops from a simple organism to a more complex one through progressive differentiation. And so if we start as a single cell that separates and differentiates into separate cells of the same kind that then separate and differentiate into more cells of different types, and that's human development, that's biological development. And so that's one of the factors that we do consider in motor development. But it's the process by which the environment influences or alters genetic expression is where epigenesis comes in. It generally occurs in an orderly sequence based on history, but we can see changes through history when sociological traumatic events have happened. There have been genetic changes in the children born to pregnant women during that time. There's studies, about the levels of cortisol in babies born to women who were pregnant during the Holocaust. And so epigenesis comes into those factors. But it basically sets up like a pyramid with a foundation on which the next layer overlaps the preceding one, similar to Maslow's hierarchy. And the pyramid allows for more growth and change in more than one direction at the same time. And so it's often described like a growing sphere than a pyramid. In order to progress in our motor development, we have to follow along a developmental sequence. And that's generally recognized to consist of the development of head control, then rolling, then sitting, then creeping and walking, the typical ways you would expect a baby to progress in their natural development. And we call these things motor milestones in therapy. The rate of change in acquiring each of these skills varies from child to child within a family, among families, and among families of different cultures. So we can't expect the same rate of progression from one child to another, whether they are siblings or live across the globe from one another. We have to understand that these are normative values, but we are always looking at individuals specifically. Oftentimes with motor milestones, our sequences will overlap and a child can work on several skills at one time. Lower level skills do not always have to be mastered before moving on, but it's sometimes important to establish them for foundation to progress to those skills. So that being said, there are phases that children may bypass, like some children don't crawl. They go from army scooting to walking because they skip the crawling phase. And so that doesn't hinder their ability to progress to running or jumping or any of those things, but they skip that motor milestone. And so it's important to know that we do need foundational characteristics, but not every single one has to be checked. We've talked about this, but just a reminder that development happens in a cephalocaudal direction, proximal to distal, and we see dissociation and fractionation before we see controlled specific movements. So what that means is that we have postural development that happens from neck movement followed by trunk control, and then trunk followed by shoulder, elbow, fingers, and that development proceeds from mass movements to specific movements or from simple movements to more complex movements. The ability to separate movement in one body part from another part is dissociation of movement, and we don't get that until we progress in our motor control. We need to promote stability and variation in our interventions for maximizing our developmental motor control. And so periods of stability and instability of motor actions are going to be observed throughout the entire sequence of motor development. Our goal is to always promote the most stability, but understand that as a child transitions from one milestone to the next or one position to the next, they're going to likely see a regression in their stability as they meet the new demand challenges. At each stage of development, abilities emerge, merge, regress, or replace, and motor abilities are learned in one context. They may need to learn in a different context and be applied different ways. Because of that need to apply things in different ways, we want to consider variation and variability. The initial phase motor patterns are extremely variable as the mover explores all kinds of movement possibilities. And so we need to learn to adapt to their variability while they create consistency, but also present enough variability that they can gain control in various situations. Sensory information is generated and shapes the development of the nervous system. Self-produced sensory-motor experience plays a pivotal role in motor development, and so the child being active in that sensory exploration is a huge part of motor development. All basic motor functions reach a beginning stage of secondary variability around 18 months, and this includes posture, locomotion, reaching, and grasp. Like any patient, we have to consider the biomechanical factors that influence their ability to complete things. And when we're looking at the pediatric population specifically, we need to look at not only their biological chronological age, but also their gestational age, because babies born preterm are going to have a different gestational developmental age than their chronological age. And that needs to be considered in how we approach treatment. Factors affecting movement include biomechanics such as muscle length, the level of neuromuscular maturation, and postural control. Full-term babies are born with a predominant flexor muscle tone, and so that's why newborns are typically in that flex position with their knees to their chest, their arms rolled in, their elbows bent, and that flexor tone is natural for that stage of life, but is also part of why tummy time is important to break up that flexor tone. As development progresses, active movement toward extension occurs if they are placed in prone. If we don't get a patient or a baby in prone, they will not have enough stimuli to break that flexor tone and encourage strengthening of those extensor muscles. Tummy time assists in the development of secondary cervical curve as the infant must extend and lift its head to turn. There's a risk of plagiocephaly if the infant is not placed in prone. So plagiocephaly is going to be that flat spot development. And so development of the flat spot, because they've laid on that part of the head too much, can then result in development of torticollis, because now they have difficulty rolling the head off of that flat spot, so they develop shortening of the sternocleidomastoid. Tummy time is essential to development. Without it, the ability of an infant to lift and turn its head is diminished. And so if there's one thing you can advocate for infants, it is to get their parents to participate in tummy time. A lot of babies don't like it initially, especially if they haven't had exposure to it, because it's a new sensory position, breaking up their natural tone, but it is essential for motor development. We're now going to jump into some of the motor skills and the ages in which we anticipate those milestones to be reached. As you are studying these chapters, I would make sure that you familiarize yourself with the different influences into development, including Erikson, Maslow, and Piaget's theories. But as well, I would familiarize yourself with the ages that motor skills are supposed to be achieved at. So the developmental process happens with growth turning to maturation, turning to adaptation. So with growth, we have any increase in dimension or proportion. Failure to grow or discrepancies between two growth measures can be an early indicator of a developmental problem. And so that's part of why when babies go to the pediatrician, they're constantly measuring their length, their weight, their head circumference, and comparing those growth measurements to ensure that there's proportionate growth across all body regions. Once the expanding portion has occurred, then we get to maturation, which is the result of physical change caused by pre-programmed internal body processes, and they are genetically guided. Once maturation has occurred, we go to adaptation, which is the process by which environmental influences guide growth and development. Adaptation occurs when physical changes are a result of external stimulation. So we grow from the inside, we mature from the inside, we adapt from the outside. Looking at these early motor skills, for the infancy period, we expect babies to achieve head control by 4 months. And so no head lag with a pull to sit means that if you were to have the baby in supine and grasping by their arms, pull them up to a seated position, are they able to maintain a neutral spine, or does their head fall back and lag? And that head control can be assessed with that motion. And that is one of the videos in your Physio U videos that I expect you guys to watch. Roll segmentally supine to prone should happen by 6 to 8 months. Typically, babies can roll prone to supine before they can roll supine to prone, as long as they are given adequate tummy time. Because when you are in prone, you have access to your upper extremities that you can push with, and that makes rolling from prone to supine easier. Sit alone should happen by 6 to 8 months. So that means without any kind of support, they're able to maintain a seated position. Creep reciprocally and pulling to stand is 8 to 9 months. Creeping is also known as crawling, so use those pretty interchangeably. Creep reciprocally, again, is being able to alternate upper and lower extremity motion. Cruising is walking along furniture, so that should be achieved by 10 to 11 months. And then walking alone without any upper extremity support should happen by about 12 months. And this table is on page 78 in your textbook. With our progression of gross motor skills, we should also see a progression of fine motor skills. I'm not going to read all of these off to you, but they are on page 78 of your textbook. These are looking at the reaching, grasping, and release progression. And so, again, as you can see, there's a greater ability to connect fine motor skills as the child ages. Let's dive into birth to 6 years. Important stages. I would familiarize myself with this table. 1 to 2 months, you see internal body processes stabilizing with basic biological rhythms established and a spontaneous grasp and release. 3 to 4 months, babies start developing forearm support, so we can start getting that prone on elbows position. Head control is established and they develop midline orientation. 4 to 5 months, they have anti-gravity control of extensors and flexors initiating so that they are able to support their head in an upright position that should then progress to the trunk. Bottom lifting is present, so they start to get some more hip mobility there. By 6 months, we see strong extension and abduction of the limbs, so they are able to put the arms out into the sides a little bit. There's complete trunk extension present. Whether or not they can maintain it is a matter of development, but they're able to get an upright position. They can pivot on their tummy, sit alone, and have spontaneous trunk rotation so that they can turn. Trunk control begins around 7 to 8 months and develops along with sitting balance. So if they are delayed in getting to a sitting position, then they will be delayed in developing that trunk balance. By 8 to 10 months, we should see movement progression with crawling, creeping, pulling to stand, and cruising, trying to become more mobile. 11 to 12 months is typically when we see independent ambulation, and at this age, a baby may move in and out of a full squat. 16 to 17 months, they carry or pull objects while walking. This is different than pushing objects, which happens earlier, typically prior to independent ambulation. That's usually associated with the cruising. They can also walk sideways and backwards by 16 to 17 months, so we're able to change directions of ambulation. 20 to 22 months, they easily squat and recover a toy, and by 2 years old, they have an arm swing present with ambulation. Heel strike present with ambulation. Other gait mechanics are still developing. We're going to go through a description of these different age ranges so that you can kind of conceptualize what you expect that age patient to present like, and you can understand what goals you might be working towards in therapy. Remember that you guys are going out on pediatric observations on the 20th, I believe, and so keeping this information in mind for your observations will be very important. So the infant birth to 3 months range. Newborns assume a flexed posture regardless of position due to that physiological flexor tone. So yes, we want to put them in prone to break up that tone, but they're still going to engage some of that flexor tone. This child will be able to lift their head unilaterally and then progress to bilaterally. Neck and spinal extension develop, allowing the head lift and turn and hold in midline. By 3 months, the infant can lift their head to 45 degrees from their support surface, which allows them to support on their forearms. So that's being able to do that prone on elbows propping. Pull to sit in supine presents with a head lag. So if I pull the child's arms from that supine position, I expect the head to lag back behind the body. Postural control of the head is not yet established. Weight bearing through the arms and shoulders provides sensory awareness, and they are able to see their hands, and so we want to promote that weight bearing. In supine, we'll get random arm and leg movements with the legs typically staying flexed. Asymmetry is present, so we might see the asymmetrical tonic neck reflex, which is when you rotate the child's head to one direction. They would extend the arm on the side that the head is rotated towards and flex the elbow of the opposite arm. And so this can often be referred to as the fencing position, but the ATNR is one of those reflexes that we expect to integrate as the child ages. Their hands should open up from a fisted position as they progress through this 0 to 3 months. Their eyes and hands link to allow reaching, grasping. They start to connect that they can see their hands, they can move their hands towards what other things they see. Primitive rolling may be seen with their head turned to one side. The benefit of the ATNR reflex is that when the child turns their own head to that side, they're already starting with an arm extended so that it doesn't get in the way of their rolling. And that's part of how those reflexes can be helpful in the early stages, but if they don't integrate as the child progresses, they can limit their ability to complete functional movements. The body may rotate as a unit along with the head. There's typically not segmental separation of the trunk, and turning as a unit as a result of the primitive neck righting reflex. 4 months, we see posture and movement change from asymmetrical to symmetrical, so we should start to see integration of that ATNR. They're now able to lift their head in midline past 90 degrees in prone, so they should be able to look all the way up. Pull to sit in supine, the head is in line with the body, so we no longer see that lag. They are able to find midline in supine and bring their hands to midline and see them. They can bring both hands to the mouth and they can play with toys with both hands. The hallmark signs of 4 months are head control and midline orientation demonstrated by the head lift past 90 degrees in prone and keeping the head in midline in an upright and tilted position. So that ability to understand upright orientation and midline orientation typically occurs right around that 4-month period. At this age, they attempt to assist in trunk control and in supported sitting, and so you can start to decrease the support needed at the trunk and push into that zone of proximal development. They independently move in supine and prone. Pelvic mobility begins in supine, so they're able to engage in their own pelvic tilts when in a supine position. And active hip flexion in supine produces that posterior tilting, so they're starting to coordinate how their leg movements can assist with their pelvic motions. At 5 months, We see anti-gravity neck flexion, which means that they can lift their head against gravity in supine. So whereas we were talking about being able to lift the head in gravity or against gravity in prone before, now they're developing that neck flexor control. From frog-like position, they're able to lift their bottom off and their support system surface and bring their feet into a visual field, so they can do slight bridging and they can bring their feet up. And a lot of babies at this age will try to eat their feet because they're newly discovering them. They provide lengthening of the hamstrings that's needed when the baby is able to pull that foot up. So discovery of the foot and then wanting to eat it is actually a biological response to stretch the hamstrings to give the child the ability to long sit as they continue in their developmental progression. We see reciprocal kicking, so instead of the feet kicking together in the earlier ages, like we would see at 5 months, they start to be able to separate those leg movements, and so we see reciprocal kicking. Extension in prone is demonstrated as a swimming posture, so we'll start to see that trunk extension instead of just the neck extension in a prone position. They make subtle weight shifts in prone on elbows, and they may be able to reach, which is demonstrating a dissociation of their head and limbs and not needing to keep those things moving together. And if they're able to achieve that, they may start to stabilize on one arm to reach with the other, again, showing that dissociation limb to limb as well. We see a lot of things happen between 4 and 6 months, and so by 6 months we should see a lot more movement and stability and trunk control and all of those things. By 6 months they become mobile in prone with a pivot. They may not be creeping yet, but they're able to do prone pivots. There's weight shifting onto one arm and reaching with the other. The weight shift is counterbalanced by a lateral weight shift of the trunk, which produces a lateral head and trunk bend away from the side of the weight shift, so they have a righting response. Leaning onto one arm is going to cause them to lean onto the opposite side of their pelvis, which then is going to have a trunk and head rotation for a correct righting response. An extended posture creates a Landau reflex and represents total body righting against gravity. So that's when, if you were to position a baby in prone and lower them as if they were falling, their body would assume this extended flying position where their head, legs, and arms would extend, again, looking like they're flying. Excessive abduction is seen in children with low muscle tone and increased range of motion, difficulty with anti-gravity hip extension. So children with low tone are holding that abducted position with decreased hip extension. They can sit upright if placed in sitting, but they're not typically able to achieve a seated position on their own yet. Sitting between feet is W sitting and provides positional stability. It does not require active use of the trunk, and I'm going to tell you right now, don't let your patients W sit. While it does increase the base of support so that trunk control is not as important, it substantially hurts the development of the hip joint, the ligaments of the hip joint, and the stability needed for progression into walking. And so don't ever let your patients W sit. By 6 months, segmental rolling is present, with prone to supine being less challenging, again because of the use of upper extremities. Anti-gravity flexion control is needed to roll from supine to prone, which develops later than extension, and so that also contributes to having an easier time rolling from prone to supine than from supine to prone. Segmental rotation is essential for developing transitional control. Being able to go from prone to a seated position has to have segmental rotation, and so that's developing during this age. The quality of movement affects the individual's ability to perform transitional movements, and the more refined the movements become, the more willing the baby is able to try transitional movements and the more successful they become with it. 4-point positions to kneeling and sit to stand do not always require trunk rotation, and so if you have a patient who is demonstrating difficulty with achieving segmental rotation, we can still work on transitions that get them to a functional position as needed, but we're not utilizing those interventions to encourage that segmental rotation, and so that's important to pay attention to what your goal is. When balance is lost in sitting, the arms extend for protection, anterior or forward, and that's where those protective responses start to emerge, like the reflexes we discussed from chapter 3. They like to bear weight on their lower extremities and bounce up and down, and bouncing and rocking help to achieve postural control. And pronated reaching is mature. So if they're able to reach in a pronated position, like the functional grasp that we typically utilize, that's demonstrating maturity. We just keep on keeping on. At 7 months, trunk control improves in sitting and allows to free one or both hands for playing and sitting. So at 6 months, you may see both upper extremities secured to the ground to maintain support, and as they get stronger with that trunk control, they're able to lift one or both to engage in play. They can narrow the base of support in sitting by adducting the legs, so we can start them in a wide abducted position to increase stability. Remember, not W sitting, but just an abducted hip position. And as the trunk control improves, we can narrow that base of support by bringing the feet together. Dynamic stability develops from muscular work of the trunk. Lateral protective reactions begin to emerge at 7 months. The unilateral reach and the ability to transfer objects in hand starts to emerge. And so the more that these actions happen closer to midline, the less demand is placed on the trunk, and so the easier time the baby has with performing them. Upper trunk rotation in sitting is demonstrated with reaching in all directions. The body moves more segmentally, so we're starting to see that dissociation, fractionation of movement. The arms move across midline, indicating dissociation of the arms from the trunk, and we see supinated reaching as well. At 8 months, they're able to move in and out of sitting deliberately, so that transition has been overcome. They may attempt to bear walk or bear weight on their hands as they walk, and so bear walking is different from crawling, is that bear walking involves your feet being on the ground instead of your knees being on the ground with crawling. There's some type of pre-walking progression, whether that's belly crawl, creeping, sitting, hitching, whatever the child is trying to move and become mobile. They may push for locomotion, so utilizing those walkers to help try to push and create stability for creating that locomotion. And then pulling develops with increased strength in the shoulders and upper back. At 9 months, babies are constantly changing positions. In 4-point, they have a rocking that they can do that helps to dissociate the pelvis from the trunk. Hands and knees requires more stability and the need for creeping, which remains their primary locomotion at this age, even if they've achieved a pull to stand and can cruise along furniture, because creeping is faster for them. A very small percentage don't creep, but one of the benefits of creeping is that it requires that counter rotation of the trunk segments, and that's important for the erect forward progression. Extension of head, neck, back, arms, and dissociation of the arms and legs from the trunk is also important for creeping, and that's important for all functional movements. And so it's not 100% necessary step, but it is a really helpful step in motor development. Children practice creeping about 5 hours a day. They can't typically balance in half kneeling or tall kneeling at 9 months. They only learn to walk when they're strong enough. Early standing includes leaning at the couch or table for hands-free play with their legs abducted for a wider base of support, with their foot responding for balance. They practice weight shifts side to side in standing at 9 months and dissociating their arm and leg movements from the trunk in a standing position as well. 9 months to 12 months is going to kind of encompass that range that we just discussed. At 12 months, the infant becomes a toddler, which isn't identified on any of the timelines that we looked at earlier, but it is an important distinction for the pediatric population. We want to make sure that in this range between 9 and 12 months, when they are learning to walk, that we aren't giving them walkers too early and giving them something that they are leaning on more than they should, because this can inhibit the development of their upper body and trunk strength that they need for walking without any kind of assistance. And it can limit that prone progression. Remember that sequences through quadruped and tall kneeling and excuse me, the pelvic control needed at the hips for tall kneel to stand. At 12 months, they typically are holding their arms in high guard, which means that their scapula are adducted, their shoulders are externally rotated and abducted, their elbows are flexed, and their wrists and fingers are extended. And if you just think of a toddler walking around, you can imagine the waddling with their arms up, and that's that high guard position. As their balance improves, Their arms move to a mid-guard position and then progress to a low-guard position. The beginning walker keeps the hips and knees slightly flexed to bring the center of mass closer to the ground because that creates greater stability for them. There's very limited ankle movement in initial walking, and so that's why we don't have that heel strike initially. They walk with that flat foot. They take small steps slowly, and remember that kind of waddling pattern. And as the trunk stability improves, the legs come into a more adducted position to narrow that base of support. 16 to 18 months, we see them at ease with walking, and they can carry or pull a toy because they've improved that strength. They go up and down stairs with help, usually one step at a time at this age. They've not progressed to reciprocal stair climbing until usually 4 or 5 years old. They'll creep up the stairs alone and creep or scoot down. They will walk sideways and backwards, so they've developed those different directions of locomotion. They'll come to stand from supine by rolling to prone, pushing up on hands and knees, or hands and feet, and assuming a squat and rising to stand. The typical arm swing and heel strike comes into play around 18 months. The first step down is... Hold on. The first step down is jump after able to walk down step holding hand. That bullet point is written really poorly, but when they progress to doing stairs by themselves, they first start by going downstairs, and that typically starts by jumping downstairs. And so you will see kids who are able to jump off of a bottom step well before they're able to climb up any of the steps without somebody. And that will start with holding a hand, and then they will progress to doing it without somebody. And they can momentarily balance on one foot, but they have poor single leg balance at this point. At 2 years old, they can step over low objects. Obstacles become less and less inhibitory as they develop. The true running starts to occur where they have both feet off of the ground. The gait becomes faster with arm swing and reciprocal steps becoming bigger and more symmetrical, and there's more time spent in a single limb stance because single leg balance has improved. They're able to go up and down stairs one step at a time. They can jump off a step and take a two-footed takeoff, so it's both feet launching off instead of one foot like they're stepping down. They can kick a large ball, and they can throw a small ball. At 3 years, they're hopping and galloping and skipping. They start at 3 years and progress through about 6 years is when we expect them to be more proficient with those skills. They should be able to pedal a tricycle. They can climb a jungle gym or a ladder with developing upper extremity strength. They can achieve balance in a tandem stance and tandem gait. They have a single leg stance of at least 3 seconds. They can make sharp turns when running. They can balance on their toes or on their heels in standings with that reduced base of support. They have a reciprocal gait to ascend stairs, but they do not have a reciprocal gait to descend stairs. They have a two-footed takeoff and land that's more mature, so they can have more of that jump. And, imagine doing box jumps. You want to have a symmetrical reciprocal launch and land. That starts to develop more around this 3 years, the ability to maintain that symmetry. And hopping on one foot 1 to 2 times on the preferred foot at 3.5 years. So their dominant leg, they can start to hop on that side 1 to 2 times around 3.5. At 4, they can hop on that preferred foot for 4 to 6 times, so they're developing more ability for distance travel in a hop. They have a rhythmic, relaxed gallop, so there's a greater rhythm to any gallop that they engage in. They start to descend stairs with alternating feet so that stairs become reciprocal. They can catch a small ball with outstretched arms if it's thrown to them. They can throw a ball overhand if it is greater than 10 inches. So it can't be a small ball, but they can throw a bigger ball as long as it's also small enough for them to grasp. But that says 10 feet, and so they can throw a ball a greater distance at this point as well. 10 inches is a big ball, and so we want to keep in mind they can throw a bigger ball because smaller balls they tend to not be able to relax the grasp of, but they can't throw something that exceeds the size of their hand. And so we want kind of that mid-sized ball, but the point here is that they have an increased distance with their throw. They demonstrate an immature striking behavior, and they can kick a ball rolled to them approximately 12 feet in the air. And so again, we're just increasing the distance on those motor skills that were developed at an earlier age. And between 5 and 6, we get a lot of refinement of those skills that have been developing since age of 3. So they can stand on either foot for 8 to 10 seconds, not just their preferred or dominant leg. They can walk forward on a balance beam, so that tandem gait has progressed to being able to do it on an elevated surface. They can hop on one foot 8 to 10 times now, so we've increased that. They can make a 2 to 3 foot standing broad jump, so it's not just the symmetry of the landing and launching, but also the ability to increase the distance there. They can skip on alternating feet. They can run and kick a rolling ball up to 4 feet. They can stand on one foot for longer than 10 seconds with their eyes open or closed. They can continue to progress their tricycle to riding a bicycle or roller skate. And a child masters the adult form of running, throwing, and catching between 6 to 10 years. So obviously we aren't done growing at 6, and we aren't done developing motor skills. Those things are refined for the foundational skills that we need from 3 to 6, and then we build on them from 6 to 10, and then we selectively choose which ones that we retain and refine versus which ones that we kind of get rusty at because we don't utilize them. If you were to race a child in a crawling situation, there's a good chance that the child would beat you because you probably haven't crawled as recently as they have. And so that's part of the pruning process that happens with motor development as we progress into adolescence and adulthood. So my word of advice for you on this chapter is to go through and figure out a way that you can conceptualize what a child at each one of these ages looks like, and remember the different motor skills and motor milestones that we expect at those ages so that you're able to understand what a treatment plan should look like and what our goals are going to be when a child is of a certain age, whether there's a developmental delay or whatever the case may be.